Hello, welcome to the Neuro Crash Course run by the Med Crash Course series. Apologies in the delay in getting this up. I wanted to re-record it just for some clarity and to avoid some of that background noise that was going on. So apologies for that. I'm Misha, I'm a medic at the moment at St George's, and yeah, we're going to go through some key intro topics for neuro. So today we're going to be going through sensory physiology and perception, proprioceptors, the auditory system and the visual system. And apologies if you hear my cat in the background. And this is just meant as a crash course to get you more comfortable with the topics, because neuro can be quite intimidating. And you may see some more of me a bit later on as I hold various revision sessions for neuro for Georges throughout the year. So starting off with sensory physiology and perception. Just a very quick reminder on action potentials. When your neuron is at rest, your voltage-gated channels are all closed, and inside of your neuron it has a membrane potential of -70 millivolts. When a stimuli interacts with that neuron, so it gets triggered, the ion channel may open, and these are the sodium channels, and as ions pass into the cell, they begin to alter the membrane's charge. Okay, so you can see on the top left graph, the voltage begins to change as we're getting more positive ions drifting into the neuron. And it will begin to approach a very important number, or threshold, which is -55 millivolts. At -55 millivolts, what you'll notice is that once it hits this, all of the voltage-gated sodium channels in that area will open. And that's why in the top right image, you'll see it rises very, very quickly. That membrane potential rises very quickly. And that's because you get this flood of positively charged sodium ions entering the cell, and it rapidly depolarizes your neuron. But it doesn't stay like this for a long period of time. Once you reach about +30 millivolts, there's a conformational shape change that happens to your sodium channels, and essentially they close. And what you'll see is that your potassium channels will then open to let out potassium ions, because you want to try and get back down to equilibrium. You want positive and negative to be equal on both sides, so the potassium channels open, and that's what you're seeing in that bottom image as the neuron repolarizes, so all of that positive charge leaving the neuron. For a second, what you'll notice is that it slightly overshoots that -70 millivolt, and this is because the potassium channels can't close quick enough, and this is basically the refractory period. So in this point, you won't be able to start another action potential until it gets back to its -70 millivolt area. In terms of what is actually happening when the action potential reaches the end of our neuron, so the charge that reaches the end of the neuron will open calcium channel, voltage-gated channels. The calcium will diffuse into your neuron, attach onto vesicles, and move these vesicles towards the edge of your neuron, and then through exocytosis release the neurotransmitter within inside that vesicle into the synaptic cleft. So I mentioned the word threshold, and there are 3 key thresholds that we need to know about. You have an action potential threshold, which is the membrane potential at which action potentials are triggered. So this would be the -55 millivolts, and this is a function of the voltage-gated sodium channels and is treated as a constant. Activation threshold is the minimum stimulus strength that will depolarize a receptor enough to generate an action potential. And sensory systems use receptors with a range of different activation thresholds. So, for example, this is part of the reason why we're able to hear different frequencies of sound and see different wavelengths of light. And there's also perceptual thresholds, which is the minimum stimulus strength that will generate enough action potential to be detected. So we can actually clinically test perceptual thresholds if you're sat in a dark room and then someone at the other end of that room ever so slightly turns on a light. You'll be able to know when that person that you're testing is able to see the light, and that's their perceptual threshold, so how low or high the light needs to be for them to detect it. Just some more key words. We have sensation and perception. So sensation is the awareness of a physical stimulus through your senses, whereas perception is your ability to apprehend or become aware of something through your senses. And perception uses our knowledge of the world to organise the raw data of sensation. So this is why, for example, if you're swimming in the ocean and you feel something brush up against your leg, in your head you might go, okay, I'm in the ocean, I know there are sharks here, that must have been a shark, and that's just relying on your touch sensation. And then when you look down, your eyes can tell you it's seaweed, and you know in your head seaweed is not a threat. So your perception comes from knowledge inside of your head as well as the data of your sensation. So there's this key phrase that you might hear get used where there isn't a single representation of a stimulus, and essentially what it's trying to say to you is that there are different receptors in your skin, for example, that detect different sensations, and they all project up to your cerebral cortex and using different cortical columns within your brain. And these different modalities of sensation terminate in different columns, but all of this information will get combined to allow for the perception of that stimulus. So using my ocean example, you've used your sensation of touch as something's brushed up against your leg, but then you use your visual system to identify what that object is that's brushed up against your leg. So you're using multiple senses or multiple receptors to identify what a stimulus is. There are quite a few different types of receptors that we need to know about, and quite a few of them are self-explanatory. So we have photoreceptors, which detect light, which is for vision. You have chemoreceptors, which detect chemicals in the air and in the saliva. So that would be for smell and taste. And there's also chemoreceptors, which detect inflammatory chemicals, such as histamine, and that's used for injury detection. We have thermoreceptors, which are for temperature detection. And then we have mechanoreceptors, which have a bit of a wider range of use. Pressure on your skin or musculoskeletal system can be used to interpret touch and proprioception. Mechanoreceptors can help detect head movements and identify your body's equilibrium, sort of making sure you're standing straight. And also we use mechanoreceptors to detect sound waves for hearing. And we need to know a brief bit of anatomy here about the somatosensory pathways. So how do we get from our senses, or where we're picking up the sense, to our brain? So our primary afferent, which is any receptor, say a mechanoreceptor, detects a stimulus and will send an action potential via the primary afferent or the primary neuron. And the primary afferent, sorry, I just messed up what I was saying then. The receptors are releasing glutamate, and this release causes something called an excitatory postsynaptic potential, or a graded potential, on your afferent, which will summate together to trigger an action potential if that threshold is reached. So that was a lot of fancy words to say that just one activation of a receptor won't necessarily activate your primary afferent neuron. What happens is receptors will trigger small amounts of depolarization, and it's the summation of lots of those receptors releasing lots of tiny charges to the primary afferent neuron, and once they all add together and hit that -55, it will then trigger that action potential in the primary afferent. The primary afferent neuron will then enter your dorsal column of the spinal cord, where it synapses onto the dorsal column nuclei, and this is where it becomes a secondary neuron. It travels up via the medial lemniscus, through the medulla into the thalamus, and we have to know exactly where on the thalamus, and it is the ventral posterior thalamic nucleus, and this is where it is synapsing onto your tertiary neuron. This neuron then travels up via the internal capsule in the white matter to your primary somatosensory area in the parietal cortex. And something that we need to get an understanding of is that not all of our sensory signals are we consciously aware of. So some of them get sent to our subconscious. One of those reasons is for movement, so proprioception and vestibular sensations give input to our motor pathways so that we can figure out how our body's moving and if this is correct. It would be a bit annoying if we had to manually control that. Autonomic responses, so olfactory sensations, for example, will trigger salivation and gastric motility to begin the hunger sensation. And again, just by smelling something, you'll get hungry. If you had to smell something and then tell yourself to feel hungry, it would be a bit inconvenient. Our body wants to be the most efficient it can. And there's also behavioural reasons, so visual or olfactory food stimuli can initiate feeding behaviours. But this isn't the only place where food gets where sensory signals get sent. So they also get sent to our arousal system. So sensory signals will get sent through lots of modulatory pathways, which you may have come across. And the main reasons that we need to send signals to our arousal system are for sleep and wakefulness. So input through our senses can wake someone, which is why a loud noise would wake you up from your sleep. And no sensory input can induce sleep. So this is why a lot of people use white noise to mask auditory stimuli, create a very neutral input, and make you fall asleep quicker. You need it for focusing attention. So focusing through one sense can suppress the others, which you may have noticed if you're driving around and you're trying to find a house that you've never been to before. You might need to turn down the radio so that you can see better, so that you can focus more on your visual system almost. And you also need to send signals to your arousal system in order to switch attention. So a sensory stimuli can recapture our awareness. Very briefly, I just want to cover all-in-one versus specialised receptors. And what happens when they're damaged, essentially. So all-in-one receptors, such as our peripheral nerves, are able to regrow part of its axons to re-innervate areas, whereas specialised receptors, such as the photoreceptors in our eyes, are necessary and separate cells from their afferent nerves. So once they're damaged, they can't be replaced. And what I just want to sort of bring your attention to is two key receptors and how they can be damaged. So photoreceptors, they are very, very easily damaged by high intensity light, which is why why you shouldn't stare at the sun. Genetic mutations, metabolic diseases, and malnourishment, specifically if you don't have enough vitamin A in your diet. Auditory receptors are also very easily damaged by things like noise trauma, which is why you might have noticed if you have an iPhone, it tells you if your music's too loud or too loud, because that is one of the things that damages your auditory receptors. There's also genetic mutations and ototoxic agents which can damage the receptors, specifically certain types of chemotherapy like cisplatin and aminoglycoside antibiotics. If only a receptor is damaged, but the afferent system is intact, we can actually manipulate this to our benefit. So we can use devices such as cochlear implants to electrically stimulate the afferent nerve in place of the auditory receptors. And this can then be interpreted as a sensation and allow the person to perceive sound. It does sound very different from how normal auditory sort of transduction of sound is. So people who have cochlear implants might describe sound as being quite different, and that's because it's being artificially simulated. But yeah, and this is very difficult to do for the visual system, and they haven't quite figured out how to do that yet. Now, how does putting pressure on a fingertip get converted to a receptor potential? So any pressure on your Pacinian corpuscle, which is one of the main mechanoreceptors in your skin, will bend the cell membrane of that Pacinian corpuscle, and that bending opens up sodium channels. And so then you get small amounts of sodium entering, and it causes small depolarization, so those graded potentials I mentioned earlier. And if they summate together and it's big enough, and they hit that minus 55 millivolt threshold, then they'll fire an action potential. So you can see on this graph quite clearly that sort of multiple tiny graded potentials coming together to hit that threshold. Now, every nerve has a receptive field in which it can detect a stimulus, and the size of this receptive field will vary based on the nerve that it is. And depending on how sensitive that area needs to be will alter how many receptors will converge onto the same axon. And this is why your brain can't differentiate between two light touches and one hard touch if it's within the same receptive field, as it only creates one action potential. Okay, so if you see on the image, if the green and the blue pin touch at the exact same time, those action potentials sort of triggered by the Pacinian corpuscle will add together onto the primary afferent. It won't come across as just one stronger or two less strong action potentials, because that's not how they work. We know that once you hit minus 55, it will go all the way up to plus 30 and back down again. Okay, and if we were to press just really hard with the blue pin, it would also do the exact same thing. It would just hit the minus 55 millivolt threshold, go up to plus 30 and back down again. And this is why we can read Braille with our fingers, as the receptive fields are really, really small, so they can differentiate between the dots, but we can't do that with our forearm skin because the receptive fields are larger, and you'd read the Braille dots as one large dot. Another thing to be aware of is that the more innervation you have for an area, the more cortex you need to deal with the input. So if you've seen the human homunculus, they'll have really large hands and really large lips because they have very, very tiny receptive fields, so we can pick up as much detail with our senses as possible. Okay, so that idea is all spatial resolution. We then have a concept called temporal resolution. If you're tapping the same afferent repeatedly, the afferent might not be able to respond quickly enough because of the refractory period. And because of this, it causes repeated action potentials, which are no different from an action potential generated from continually touching that afferent. So your brain will interpret this as one long touch rather than multiple small touches. Okay, so because our body just can't respond quick enough, it's not able to, like the action potentials can't get generated that quickly because of the refractory period. Our body will often interpret lots of quick touches as one long one. Now, Pacinian corpuscles can respond to very high frequency stimuli, but each receptor is different and will have a different frequency at which it can respond. And so from this, we need to bring in a concept called sensory system adaptation. So if an afferent is repeatedly stimulated and the stimulus remains constant, then the afferent will reset its sensitivity and resting membrane potential from the depolarized level back to the normal resting level. Okay, so if it keeps getting sort of stimulated, it will go, okay, we're going to reset our resting membrane potential to a higher value because nothing's changing, it keeps happening, and we don't want to waste anything effectively. So then action potential firing will go back to its normal spontaneous level. So this means that if a stimulus increases in strength, then the afferent can respond and detect its increase in strength. And a great example of this is our clothes. So our skin would be constantly overstimulated by the pressure of our clothes on our skin, but our sensory system adapts to ignore it so that we only respond to a change in the pressure. And then we have a slightly more complicated sort of topic to cover, which is lateral inhibition. So a stimulus is detected by a primary afferent and sends an action potential to the secondary afferent, which mirrors the primary. Instead of mirroring the primary, the secondary neuron will actually communicate with inhibitory interneurons to dampen down the response of other secondary afferents to prevent the wasting of action potentials. So it's essentially saying nothing interesting is happening here right now. Now, if this stimulus is increased on one primary afferent, then the secondary afferent will completely inhibit the surrounding secondary afferents, and this will show to the brain that there is an increase in stimulus at a certain point. So in short term, lateral inhibition is just something that enables our body to highlight locations where stimulus strength is changing. Right, there's also a bit of the topic of dynamic range, which is the adaptation. Basically, adaptation and lateral inhibition dampen down responses to homogeneous temporal and spatial stimulation. That is what we've just covered. Therefore, receptors will respond strongly to small changes over a very large stimulus range. Okay, so that's essentially what dynamic range is. It's that our body's able to do this adaptation and inhibition so that we're able to respond over a larger stimulus range. Now, why do we need to be aware of perceptual thresholds and receptive fields clinically? And the words are damage and disease. So basically, you can differentially affect different types of receptors, and you need to be able to choose the correct tests for each type of receptor. You can also have an increased perceptual threshold where receptors are lost, and also neural damage can disrupt inhibitory systems and lead to hypersensitivity. So there is a lot of cells and a lot of processes going on in order for us to be able to sense things and perceive what we're sensing. And anything that goes wrong along the way can become symptomatic, and you need to know how to test for that and to be aware that you need to test for it. The first condition to consider is epilepsy in the somatosensory system. So epilepsy is, in very, very short, waves of excitation over your brain. Now, if you were to get a wave of excitation due to epilepsy that goes over your somatosensory system, so over parts of your parietal cortex, the individual would feel a wave of sensation going through their body even though there's no physical stimulus. So they might report that they're actually feeling someone sort of touch them head to toe for a few seconds, but it's actually just the cause of the wave of excitation going through the brain. There's a condition called synesthesia that we need to know about, and this is, again, in short, I don't want to go into too much detail on these because you don't need to know it, but it's when your auditory input activates visual color processing areas in the brain. So whenever you hear something, it triggers a visual stimulus. So they essentially can see colors, they can see names. We have phantom limb syndrome. So I'm going with an example here. So if there is a below elbow amputation, the afferents from the removed segment remain in your upper arm. You don't go searching and remove all of the nerves, tracing all the way back up to your spinal cord. You just leave them there. So your afferents may grow into the stump that remains, because as we know, all-in-one receptors, which peripheral nerves are able to regenerate. And this means that if you were to touch a certain area of the stump, it would cause the perception of sensation in, say, a finger, because it was the finger afferent nerve, but the finger's not actually there. Also, your cortex may begin to behave aberrantly and pick up signals from elsewhere, but map it to a certain region of the cortex which is no longer there. And that might cause a sensation in a part of the body which isn't there. So you've now got this area of your brain that was dedicated to your forearm, but your forearm's not there no more, so your brain wants to adapt and give that space a different function. So it gives it to your toe. Now, anytime that toe gets touched, your brain might get a bit confused and go, wait, no, that's our forearm area, and give you the sensation that it's not your toe getting touched, but actually your forearm, which is no longer there. Hopefully that made sense, because it was a bit muddly. And we also have a pathology about where you feel pain without actual pathology. So nociceptive receptors in your cortex may become active, and this would cause the sensation of pain without a visible cause. So they may have some sort of misfiring of the nerves, for example, and they're not having a physical cause of pain, so they're not being stabbed by a knife or treading on fire or something, but their body is interpreting those sort of active neurons, those misfires, as the sensation of pain. So I've just got a few SVAs for you guys, and I'll pause after each one. So which of the following is not a function of a mechanoreceptor? You have A, hearing, B, injury detection, C, proprioception, D, touch, or E, detection of head position. The answer is injury detection. Which of the following damages both photoreceptors and auditory receptors? We have A, vitamin A deficiency, B, noise trauma, C, high intensity light, D, aminoglycoside antibiotics, or E, genetic mutations. And the answer is genetic mutations. Next question is, what is the threshold to trigger an action potential? Now, I won't read these answers out, and I will give you a few seconds. And the answer is minus 55 millivolts, which is A. And the reason I didn't read this out is because I want you guys to pay special attention to the symbols. So MV is millivolts, V is volts, and the UV or mu-V is microvolts. So this is how they can often trip you up in SVAs by, you can see minus 55, and if you're rushing, you might select any one of those minus 55s. But you need to make sure to check the units and make sure that it's correct. Alright, so in the next part of the recording, we're going to be covering proprioception. So I will see you guys shortly. Welcome to part 2, which is all about proprioception. So what are proprioceptors? They are a type of sensory receptor that monitor the movements of your own body, and they're found in your muscles, tendons, and joints. They have two main functions. First is to allow you to know where your body is, and the second is to provide vital feedback information for the control of your motor systems. Alpha motor neurons innervate skeletal muscle, causing them to contract. And they have their cell body in the anterior horn of the spinal cord, and their axons project out to a muscle where they will give a single synapse to muscle fibers. A single neuron can innervate multiple muscle fibers, but a single fiber can only have one nerve innervating it. An alpha motor neuron going down and innervating muscle fibers forms a motor unit. And an action potential in the motor unit will cause an action potential in the muscle fibers that the neuron is innervating. So here you can see where they have their cell body in the anterior horn of the spinal cord. At rest, when relaxing, there is little activity going on in our muscle fibers. Small, weak oxidative fibers are firing slightly to produce some background tone in the muscle. And this is because there is activity in the smallest motor neurons that have the smallest and weakest motor units. And the general rule is the bigger a neuron cell body, the bigger the stimulation you have to give it to get it up to fire an action potential. So a weak excitatory input into a pool of motor neurons, pool meaning a group of alpha motor neuron cell bodies in the anterior horn, which are involved in innervating a single muscle, will only innervate the smallest and weakest neurons. If you need more power, you increase the overall excitation of the pool. Then the next largest neurons will activate as they get bigger, and as they get bigger, they are more powerful, but also more fatigable. Action potential production are based on the balance of excitatory and inhibitory inputs. So a weak contraction consists of less excitation and more inhibition. So we have to have a balance between this excitation and inhibition for us to have very fine control over our movement. And a little added piece of knowledge, small motor units are red in colour and larger motor units are whiter in colour. Now we may need to change the force of contraction, and there are three ways to do this. The first is to change the frequency of action potential firing in your active motor units. The second is to change the number of active motor units, and the third is to change the type of active motor units. So going back to this image here, if you were using quite a few of these red small motor units, it may be more effective for you to go up to the next step and just use one of this bigger size. And that would happen until the largest size, so that you could reach the force of contraction that you needed. Now you may hear this term muscle spindle, which is found inside of your muscles, and this spindle is enclosed by a capsule, and surrounding on the outside are the normal muscle fibers, which we're going to call extrafusal fibers. So the muscle fibers, which are just ordinary hanging around in your muscle, are the extrafusal fibers. And then we have this spindle with a capsule around it. And on the inside of this capsule, we have intrafusal fibers. And these are a type of modified muscle fiber. These fibers still have the contractile machinery, the myosin and actin, but only at the poles, so the top and bottom end. Therefore, the ends are contractile and change length at the same time as the main muscle. The center of these intrafusal fibers are passive and elastic, stretchy structures. And sensory stretch afferents are associated with this elastic central part of the intrafusal fibers, and the afferent will only be activated if this bit stretches. Okay, so you can see that the alpha motor neuron will attach here, the red, and the gamma motor neuron is the green one attaching. So what is the role of a muscle spindle? The muscle fibers in the spindle are associated with those sensory afferents that I just mentioned, the alpha and gamma afferents, which project to the spinal cord and are able to increase excitation of that alpha motor neuron pool. When there is an unintended stretch of a muscle, the stretchy bit of your spindle gets stretched. And the stretching of that spindle will cause the sensory afferents to send signals to the spinal cord to increase excitation of the motor neuron pool innervating that muscle. There will then be an increased action potential firing and contraction of more and larger myofibers, and the muscle will contract with more force. And this can help you do things like maintain position. And it's part of the reason why you're able to control your posture. So the whole goal of this is to reduce how much we're stretching that stretchy portion of our fiber. Now, how do our muscle spindles ensure accuracy of movement? If we reach out to pick up a mug of coffee we think is empty to wash it, but it's still half full, that's the scenario I want you to keep in mind. So the mug is heavier than we expected it to be, but we will still be able to lift it accurately. As we lift the mug, it takes more contraction in our muscles to lift the mug at the intended speed because heavier weights slow down muscle contraction unless you increase the power. So as we start to lift the mug, our alpha motor neurons fire, but our muscle shortens slower than intended because the weight is heavier. The muscle spindles are not attached to tendons and are not carrying any of the weight themselves, so the intrafusal fibers receive their impulse from the gamma motor neurons and contract at the normal expected speed. So as a result, the muscle as a whole is contracting more slowly, whilst the intrafusal fibers are contracting at the speed that was intended. And this results in the center of our intrafusal fiber stretching, that stretchy portion. So the afferents get activated and go on to excite the alpha motor neuron pool, which recruits more motor units and then increases the contraction of the muscle so that you can adjust how much power you're using to pick up the mug. And at the poles of our intrafusal fibers, it's innervated by these gamma motor neurons, as I said quite a few times now. And this allows for the control of the length of those contractile pole regions of the intrafusal fibers. The gamma motor neurons do this in such a way that if we are doing a voluntary movement, the center of the intrafusal fibers will not change length if we stretch the muscle. All of the length will be taken up by the poles. Therefore, the afferents will not be activated. This is how the brain gets to turn off this reflex, by ordering the gamma motor neurons to get the length to be taken up by the poles. So on the left, we have the muscle contracting and the alpha motor neurons are active, contracting the extrafusal fibers. And at the same time, the gamma motor neuron contracts the pole of the intrafusal fibers so that they take up the length and the central portion doesn't. Okay, so we want to keep our stretchy portion the same size throughout so that our body doesn't initiate that reflex. Now the muscle spindle has its afferent, which makes a monosynaptic connection with the motor neuron. So if you have unintended stretch of the muscle, it will reflexively contract. Afferents also activate an inhibitory interneuron, which suppress activity in the motor neuron driving the antagonistic muscle. When there is an unintended stretch of the biceps, the afferents stimulate the alpha motor neuron pool to the biceps to increase contraction, and at the same time activate inhibitory interneurons that will inhibit alpha motor neurons to the triceps so that it will relax. This is done because if we reflexively contract the biceps, we need to be able to relax our triceps so that a movement can actually occur. And that whole process is known as reciprocal inhibition. Now, some SBA specific knowledge that you need to know. Interneurons are glycinergic and act through ionotropic receptors on the motor neuron. They open up and allow chloride ions to flow in, which hyperpolarize the cell, decreasing action potential firing. This is very rapid in onset, short-lasting, and relatively weak. Triceps also have muscle spindles which have monosynaptic connections with their own alpha motor neurons. So bicep afferents make synaptic connections with the inhibitory interneurons that inhibit the release of neurotransmitter from the antagonistic spindle afferents. And this is presynaptic inhibition, which has switched off the triceps reflex arc. The interneurons here are GABAergic and work through GABA-B on the axon's terminals, which are metabotropic. This, in contrast to the previous, is slow in onset but long-lasting and more powerful because you're switching off the entire reflex arc at the synapse and preventing the alpha motor neurons from being stimulated. The inhibition of your alpha motor neuron pool is done to allow us to freely turn off It's done, to allow us to turn off the muscle spindle reflex and move more freely. Descending control system pathways from the brain travel down to activate inhibitory interneurons, and if we increase the inhibition of motor neuron pool, we will decrease the contraction of the muscle as a whole. So if we do a voluntary movement and the muscle stretches, our gamma neurons will play their part, but also the brain commands the inhibitory neurons to dampen down the alpha motor neurons in their pool, preventing the reflex contraction so the muscle doesn't resist stretching. Now, a little bit about motor neuron lesions. So you have upper motor neuron lesions and lower motor neuron lesions. Going first through upper, this is when you, so neurons from the brain and sort of your spinal cord. Any damage to them will cause spastic paralysis, weakness, and increased muscle tone and reflexes. This weakness is due to no signal from the brain being sent to the muscle to contract, but you'll have increased tone and reflexes because your brain can't dampen it down. So after what we just spoke about, our brain is unable to activate those inhibitory interneurons to stop the alpha motor neuron pool from working. What you'll notice is that there is no muscle wasting, and this is because the spinal nerves, those alpha and gamma motor neurons, are still intact. So at rest, as I mentioned right at the beginning, your muscles are never truly at sort of rest. They're always doing some sort of background tone, and your alpha and gamma neurons are releasing feeding amounts of neurotransmitter just to keep those synapses working and keep it alive. So you're keeping that muscle alive, and you'll still have that reflex input because your spinal nerves, your motor neurons going to the spinal cord, is still intact. In comparison, your lower motor neurons, which are the sort of alpha motor neurons, if they get damaged, you may see flaccid paralysis, and this is because you've got a denervated muscle. You'll see the weakness. You'll actually have wasting because it's the alpha motor neuron which is damaged, so it can't release that feeding amount of neurotransmitter. And consequently, you'd also have a loss of reflexes because you can't do that stretch reflex that we spoke about. And you may also see fasciculations and fibrillations. And this is, in theory, basically what's happening is your muscle is, as a last resort, contracting as much as it can to try and send a signal to any sort of neuron nearby to say, hey, I don't have a nerve, come and find me and innervate me. So it's sort of like your body's last attempt at trying to re-innervate itself. There are around 6 intrafusal fibers in a muscle spindle, and they're divided into 2 classes. The first is the nuclear bag fibers, which are associated with type 1A afferents, and the second class is the nuclear chain fibers associated with type 2 afferents. There are some sort of in the middle that are associated with both, but we won't go into those ones. Group 2 afferents are essentially more length equals more action potential firing. So these afferents are simply encoding different lengths of muscle. They generally have a thinner, slower axon and form mainly indirect connections to alpha motor neurons, so they synapse onto interneurons first. And the fibers respond in response to the length of the muscle and are important in maintaining limb position, posture, and resting muscle tone, so that slow change in position. Improperly controlled type 2 arcs can be treated by suppressing the group 2 reflex with alpha 2 agonists such as tizanidine, and it's the group 2 afferents where if you have that loss of upper motor neuron control will cause hypertonia because nothing is interfering with the group 2 afferent anymore. Type 1A afferents fire rapidly when the muscle is changing length rapidly, but once it reaches a given length, it goes back to the original level. So it responds in proportion to the velocity of the muscle stretch. Group 1 afferents have a thicker, faster axon and make monosynaptic connections to the alpha motor neurons. They respond to the rate of change in length and are important they're important for correcting rapid unintended movements. To test these afferents, we would hit the tendon with tendon hammers and we would see short, sharp change in the muscle. This afferent is also involved in correcting perturbation in gait, so the high heels slip to the side and then being able to make your foot straight again. And loss of upper motor neuron control of this causes velocity-dependent responses, so you get spasticity. Now, how can we actually treat this spasticity and hypertonia due to our upper motor neuron no longer being able to do its effect on the type 2 and type 1A afferents? We have Botox, which can block synapses. We have oral benzodiazepines, which can boost GABA-A inhibition. Oral baclofen, which activates presynaptic receptors on the type 1A afferents. And intrathecal baclofen, which activates GABA-B receptors on 1A afferents in the synaptic boutons. You may have heard of the Golgi tendon organ, so I'm going to briefly touch on that. And what it does is it measures tension through active muscle contraction. So it squishes the 1B sensory afferent between the collagen fibers of a tendon. And it's important for determining if you can handle a weight load. So when standing, your leg extensors pull on the tendon so that the Golgi tendon can send information to stop further extensor contraction. Okay, so I'll say that again, just because I messed up a little. When you're standing, your leg extensors will pull on the tendon so that your Golgi tendon can send information to your spinal cord to stop further extensor contraction. And the extensor tendon organs switch to excite muscles during their gait cycle so that it can boost the contraction phase of the muscle. Spindle reflexes can be disinhibited just before your muscle switches from stretching to contracting to help initiate your contraction phase. Your brain also helps here. And loss of these proprioceptors can therefore lead to weakness in your gait. They might not be able to initiate those reflexes or know when to stop contracting that muscle. Ending with a few SVAs. What is a key feature of motor units? A, the largest activate first. B, the larger they are, the more fatigable they are. C, the larger they are, the more resistant to fatigue they are. D, the larger the unit, the more red in colour it is. Or E, the larger the inhibitory input, the larger the unit will activate. And the answer is B. The interneurons involved in presynaptic inhibition are A, rapid in onset, B, short-lasting, C, weak, D, glycinergic, or E, metabotropic. The answer is E. Which is a symptom of a lower motor neuron lesion? A, no muscle wasting, B, spastic paralysis, C, increased reflexes, D, fasciculations, or E, increased muscle tone. And the answer is D. So that brings our proprioceptor part of this neuro crash course to an end, and in the next segment we'll be discussing the auditory system. Welcome to part 3 of the neuro crash course, which is on the auditory system. So starting off with a bit of brief anatomy, you have an outer, middle and inner ear. The outer ear is made of the pinna and the ear canal. The canal ends at the tympanic membrane, which is where the middle ear begins, and the middle ear consists of your 3 tiny bones called the ossicles. Behind the oval window is the inner ear, and the inner ear consists of a membranous fluid-filled space in the temporal bone. In your inner ear, there is a bony labyrinth within the temporal bone, which is filled with perilymph, and inside of this is a membranous labyrinth filled with endolymph, which has an excess of positive ions. There is also the cochlea, which is the auditory part, and the cochlea spirals around the cochlear branch of the vestibulocochlear nerve, which is cranial nerve 8. And within the cochlea, there are 3 chambers. 2 chambers are filled with perilymph, which is separated by a bony shelf, which contains the nerve fibers. There is a basilar and vestibular membrane, which separate the internal chamber, the cochlear duct, which contains endolymph. And in the spiral organ, you find the auditory hair cells. Within the spiral organ is mostly supporting cells, but there are auditory receptors. There is 1 row of inner hair cells and several rows of outer hair cells. The Tectorial Membrane is a gelatinous membrane which lies over the top, and each hair cell has stereocilia on top, which look like little hairs, which project into the endolymph-filled duct. And the endolymph, as I mentioned earlier, has an excess of positive ions, which are potassium. The outer hair cells are embedded in the tectorial membrane, which link the tectorial membrane to the spiral organ and the basilar membrane. And joining the stereocilia together are a few strands of glycoproteins, which we can also call the tip link. And pulling on this tip link is what depolarizes the hair cells and allows you to hear. In terms of the composition of perilymph and endolymph, as I've sort of alluded to, perilymph has high sodium content and low potassium, and endolymph has high potassium and low sodium. And it's the stria vascularis within the ear which makes the endolymph. The outer ear is designed to channel sound waves up to the tympanic membrane, and sound waves make this tympanic membrane vibrate. The ossicles are designed to overcome the impedance step, which is when air cannot directly cause water vibrations. And the vibrations are then transmitted to the other side of the oval window via the vibrations caused by the ossicles. When vibrations go through the oval membrane, the oval window, they go up through the cochlea and they are directed into the scala vestibuli as they pass through membranes. As the sound waves pass across the membranes, those membranes vibrate. So your basilar membrane will vibrate. This vibration will cause side-by-side tilting of the stereocilia. This is done directly by the tectorial membrane on the outer hair cells. For the inner hair cells, it's the current in the fluid which causes their movement. Each tilt will cause a pulling on the tip link and relaxation, causing a depolarization of the hair cell. And in terms of where sounds go, at the apex of the cochlea, your ear will detect the lowest frequencies, because the basilar membrane is much bigger and floppier. Apologies about any background noise you may hear. So at rest, a hair cell is leaking glutamate to the afferent nerves, so they are firing a stream of action potentials as the hair cell is resting about minus 40 millivolts. So it's slightly depolarized due to the open sodium channels at the top of the hair cells. When the tip link is stretched, it opens more sodium channels and allows for cations to move across the membrane. The excessive positive charge in the endolymph drives positive ions into the hair cell, allowing for depolarization of that hair cell. Hair cells then release more glutamate and increase the amount of action potential firing. When the stereocilia tilt in the other direction, the sodium channels close and allow the cell to hyperpolarize. Louder sounds produce louder vibrations, which means bigger receptor potentials, leading to more transmitter release and creating more action potentials. Different frequencies or pitch activate different sets of hair cells. So the basilar membrane at the apex of the cochlea is broad and floppy, like I said, and at the base it is narrow and stiff. A narrow and stiff membrane will vibrate better at a high frequency, and a broad and floppy membrane will vibrate better at lower frequencies. For the primary auditory pathway, the cochlear afferent projects to the cochlear nuclei, which then projects contralaterally to the inferior colliculus of the brainstem. This then projects to the medial geniculate nucleus of the thalamus, which projects to the primary auditory cortex in the temporal lobe. The auditory pathway is tonotopically organized so that information from the apex of the basilar membrane, which is those low frequencies, goes to the anterior part of the auditory cortex, and so on. The primary auditory cortex is responsible for putting the different pitches together, and higher cortical areas such as Wernicke's area is responsible for detecting speech and making sounds make sense. It is also responsible for helping to produce the correct words. The location of a sound source is determined by comparing the sound detected by the two ears. So the cochlear nuclei projects bilaterally to the superior olivary nuclei in the brainstem, and then it projects to the inferior colliculus and so on. And this is done separately for low and high frequency sounds. For high frequency sounds, the lateral superior olivary nuclei compare the loudness of sounds in the two ears. Okay, so for high frequency, lateral equals loud. For low frequency sounds, the medial olivary nuclei compares the moment at which sound reaches the two ears. So for low frequency, it's medial and moment. Inner hair cells are responsible for being the source of auditory information. They generate the signals which your brain turns into sound. And there's only about 3,500 of them and only one row. And they do not connect to your tectorial membrane. Outer hair cells, on the other hand, each time that they are depolarized, they shorten a little bit, which pulls the tectorial and basilar membrane together. This then increases the size of the vibration, which caused the initial vibration. These are cochlear amplifiers, which amplify at that certain point along the basilar membrane, and they are embedded within our tectorial membrane. There are some vulnerabilities in the auditory system that you need to know about. The first is there are going to be quite a few conditions. So conductive deafness is the failure of sound waves to reach the hair cells, and this could be due to earwax buildup. And then we need to go through each sort of component of our auditory system and what could go wrong. So hair cells themselves, once they're destroyed, cannot be replaced. And they only have about, as I just mentioned, 3,500 of them, which our brain can actually use to interpret the signals as sound. So strong vibrations, caused by loudness, can damage our stereocilia and kill the hair cells, and this is noise-induced hearing loss. High-pitched sound is more energetic and also more damaging, but also as we age, we begin to lose our high-frequency hearing, and this is called presbyacusis. Hair cells are also at risk to drugs, so ototoxicity, and these drugs include the aminoglycoside antibiotics that I've mentioned in previous lectures, such as gentamicin, and the chemotherapy drugs such as cisplatin. For the endolymph system, we know that it's produced by the stria vascularis and removed by draining into the CSF, and this balance must be kept perfect so that you can have an ideal pressure in your cochlear duct. If pressure builds up in the cochlear duct, you may develop something called Meniere's disease, and you'll get damage to the cochlea, which can lead to vertigo and hearing loss. If you get damage to your primary auditory cortex, what you'll find is that bilateral damage does not actually cause total deafness. Damage to Wernicke's area leads to poor comprehension of language, and when they're speaking, they'll present with something called fluent aphasia, so their speech will be fluent but nonsensical. The words won't make sense. They're also unaware that they're saying the wrong words. And finally, you have the primary auditory pathway itself. So the cochlear nerve runs through a solid bone, so it can be damaged by any space-occupying lesions, such as acoustic neuromas, which will then prevent signals being sent to the brain. So which of the following statements is correct? A, we have more inner hair cells than outer hair cells. B, inner hair cells connect to the tectorial membrane. C, outer hair cells turn auditory information into action potentials which get sent to the brain. D, inner and outer hair cells are not connected to each other in any way. Or E, outer hair cells act as a cochlear amplifier. Okay, and the answer is E. Which statement is correct? Oh gosh. Sorry about that. Don't know what just happened. Okay, so which statement is correct? We have A, Perilymph has high sodium and high potassium, and so does endolymph. B, both have low sodium and low potassium. C, Perilymph has high potassium, low sodium. No, sorry, I read that wrong. C, Perilymph has high sodium, low potassium, and endolymph has low sodium, high potassium. D, Perilymph has low sodium, high potassium, endolymph has high potassium, low sodium. Or E, Perilymph has high sodium, high potassium, and endolymph has low sodium and potassium. And the answer is C. All right, and that then brings us to the visual system. So again, just as a reminder, these are crash courses that to get you more familiar with the topics in preparation for learning them. And then any revision sessions are for sort of more consolidated knowledge and to ask further questions. But please, if you do have any questions about these topics, do send us a DM on Instagram. So the visual system. Again, having a quick look at the anatomy. The outer layer of your eye is a fibrous layer called the sclera. So this is the white bit of your eye, and it becomes transparent over sort of the center of your eye and forms the cornea. Inside the eye, you have vitrea humor, and this is behind the lens, and it's a transparent, smooth jelly substance. In front of the lens and behind the cornea is the aqueous humor, which is what generates the internal pressure of the eye. And the aqueous humor hydrates the vitreous humor by diffusing backwards. In terms of the anatomy directly involved with the optics of the eye, so being able to sort of see things, the lens is held in place by suspensory ligaments which link it to the ciliary body. There is the iris in front of the lens, which has the pupil at its center, the cornea, which is primarily responsible for focusing light rays, and the iris controls how much light enters the eye via the pupil. Your lens then provides additional variable fine focus, so your cornea does most of the focusing of light rays, and your lens does the fine tuning. The retina is made up of two layers. You have the inner layer, which is the neural retina, and the outer layer, which is the retinal pigment epithelium. And looking at a cross-section through peripheral retina, on the innermost layer of the retina are the ganglion cells, which have axons. The inner nuclear layer, or the middle layer, is made up of interneurons, and the next layer is the photoreceptor layer, which is made of rods and cones. Rods are responsible for night vision and peripheral vision, and they become saturated and useless with any lighting above twilight. And cones are responsible for day vision and can see a wide range of illumination as they can constantly reset their sensitivity. The last layer is your pigment epithelium. And looking at this image that I've got displayed, you can actually tell where it is on the retina because of how much of the retina you can see. So this image is of peripheral retina as it has the whole depth of the retina. Before I go a bit more into that, photoreceptor cells are linked to ganglion cells primarily via bipolar cells. Now, bipolar cells span the entire length of the inner nuclear layer and collect information from the photoreceptor cells and then deliver it to the ganglion cells. So what I'm trying to say is that light has to travel all the way to the back layer of your eye, and then the information is sent forward to the ganglion cells. In the peripheral retinas, bipolar cells receive input from multiple cone cells, which means they are focusing a relatively large part of the image. As you go from the central to the peripheral retina, the amount of convergence onto bipolar cells increases, so the pixel size increases and the focus of an image decreases. Okay, so you're getting more photoreceptors giving information to just one bipolar cell and ganglion cell. The whole depth of the retina is translucent and light has to pass all the way through it, hence causing peripheral vision to be blurred and not as focused as central vision. Partly due to the fact that there are actually quite very few cones in your peripheral retina, it's mostly rods. And so you only see detail with the very center of your visual field or your fovea. So if you're looking at your screen right now, that's in focus, but everything around your screen that you're not looking at, you can sort of detect that it's blurred. So your fovea is in the center, which is your fovea centralis, and it's surrounded, we just have a look on the image here, by a yellowish region called the macula lucida. And this helps capture shorter wavelengths of light, which are damaging, so it protects your fovea. Around this is your central retina, and in the fovea is a pit. The interneurons and ganglion cells are all pushed to one side, so this means that light doesn't have to pass through all those nerve cell layers, and you'll get a clearer image. In terms of size, the fovea is actually 0.3, the pit itself is 0.35 millimeters, and the fovea as a whole is 1.5 millimeters. There are only red and green cones found here, and they're very, very tightly packed together. And the ganglia only receive information from one photoreceptor. So this makes a well-focused and well-sampled image with no convergence that could mess up image clarity. So the fovea is specialized for the highest resolution and the best color vision. And resolution and color discrimination decreases as you go outwards due to more convergence and overlaying tissue, which gets coarser, so there are more neurons and capillaries in the peripheral retina. For the primary visual pathway, the photoreceptors send signals to the ganglion cells, which feed into the optic nerve. The optic nerve travels to the optic chiasm, and it is here that the nasal retinal information decussates. So this means that the left nasal retinal information crosses at the chiasm, so that the optic tract contains the left nasal retinal information and the right temporal information. The optic chiasm then splits into the optic tract, which travels to the lateral geniculate nucleus. From here, there are afferent fibers which send information to the pupils to allow for the consensual pupillary reflex. From the lateral geniculate nucleus, there is an optic radiation, part travelling through the parietal lobe and part travelling through the temporal lobe, which all come together at the primary visual cortex for perception. There is also a branch which goes to the brainstem, which is responsible for the control of eye muscles and orienting responses. Okay, so the left side of an image is detected by the right side of both retina, and the right side of the retina then go to the right side of the brain. Central vision goes to the dorsal aspect of the visual cortex, and central vision has an expanded area dedicated to all of the individual pieces of information. Peripheral vision has a smaller section on the ventral aspect of the visual cortex. Very briefly, just having a look at visual field maps. These are when you're able to map out visual fields of a patient. Your fovea should be central, and 15 degrees temporally, you'll find a blind spot which is caused by the optic nerve entering the retina. And you can do what's called Goldman's visual field test, which is where an individual will stare straight at a dot, like on a screen, and then they have to press a button every time they see a flashing light, but they can't move their eyes off that middle target. The reason I bring this up is because you can get blind spots which are not normal. So these are called scotomas, which are partial losses of vision or blind spots in an otherwise normal visual field. And here are a few examples. And I'm sure you would have come across images of them so that you can identify where the pathology is. There are some key rules of vision that I want you guys to know. Left, right, up and down are all inverted. So the left side of an image is projected to the right side of the retina. The bottom of a visual field is projected to the upper part of the retina. Okay, so your brain has to flip it upside down. So flip it from upside down to the right way and then flip it left to right as well. Number 2, anything that happens in front of the optic chiasm will produce an independent pathology in the eyes, and any lesion that happens behind the optic chiasm will produce matching pathologies on the visual field map of both eyes. Okay, so those are my sort of 2 key rules to bear in mind. So going over pupil constriction, the muscle that contracts your pupil is called sphincter pupillae, and it's caused by parasympathetic input. So acetylcholine is released, and this is from your short ciliary nerves. So your short ciliary nerves have parasympathetic input which release acetylcholine. When light is shone on the pupil, ganglion cells detect this and send the information to your lateral geniculate nucleus, which pass the information to the brainstem. In the brainstem, it goes to the pretectal nucleus and then the Edinger-Westphal nucleus, which sends signals via cranial nerve 3 or oculomotor nerve to the ciliary ganglion. Then the short ciliary nerves cause contraction. This happens to both eyes when light is shone in just one. So this is both the direct and consensual light reflex, and you can see on the image that the pretectal nucleus has neurons which go to both sides of the Edinger-Westphal nucleus, so both for your left and right eye. It's just want you guys to note that your preganglionic fibers of your oculomotor nerve, cranial nerve 3, are very vulnerable to raised intracranial pressure because the parasympathetic fibers are on the outside of the nerve. So they can easily get sort of squished first. So this will cause your pupils to stay dilated because they're unable to constrict. So if you think about like Grey's Anatomy, for example, when Derek Shepherd's pupils were fixed and dilated because he had raised intracranial pressure. For pupil dilation, the muscle that dilates your pupil is dilator pupillae, and this happens normally when the constrictor isn't pulling as hard. It can also happen instantly due to the sympathetic nervous system, and these signals are sent via the long ciliary nerves. Okay, and your sympathetic nervous system, it's the neurotransmitter, sorry, is what I'm trying to say. The neurotransmitter released is noradrenaline. So, as I mentioned at the beginning, the cornea does most of your light focusing, and then your lens does the sort of fine tuning. So we can alter our lens to focus our image a little better. So close objects can be brought into focus by making our lens fatter, and far away objects can be brought into focus by making the lens thinner. By contracting the ciliary muscle, you reduce tension in the suspensory ligaments, and this allows for your lens to become fatter. And by relaxing the ciliary muscle, the suspensory ligaments become tighter, causing the lens to become thinner. And this is because of that parasympathetic control via those short ciliary nerves that we mentioned just a second ago. In terms of pathologies that you need to know, myopia is another word for short-sightedness, and this is when the optical apparatus are too strong for the length of the eye, causing the image to focus in front of the retina, so that by the time it gets to the retina it is blurred. So they can see close, as your retina is able to thin out slightly, but it cannot thin out enough to be able to put distant objects into focus. And we can correct this by using concave lenses, which help decrease the power of the optics. And concave are negative lenses, so your eye prescription being like -2, for example. Hypermetropia is also known as far-sightedness, and this is when the optics are too weak for the eye. So objects are being focused behind the retina. This eye can only focus on far objects by increasing the refractive power of your lens, so making it fatter, but it can't get even fatter to try and focus on nearer objects. This can be corrected with convex lenses, which help strengthen the optics. So these are positive lenses. So your prescription will be +3, for example. Presbyopia, which I'm sure you might have realised, having heard presbyacusis, is related to age. So presbyopia is when your lens begins to degenerate with age, it becomes stiff and focus is fixed. You can't see it, but you can't see at any distance particularly well, and this is why you'll notice your grandparents often having multiple pairs of glasses for different distances. So their lens can't get particularly fat or particularly thin to adjust. Cataracts is when your lens degeneration becomes so bad that the proteins become opaque and you can't see through your lens at all. And you can have an operation to remove your lens and get it replaced with a prosthetic. Vitreous degeneration. So within your vitreous jelly, proteins can clump together because as we age, the vitreous just sort of degenerates, gets a bit dry and sort of clumpy, and all of the proteins can clump together, and it can actually pull on your retina and cause it to detach. But for vitreous degeneration, you'll often see shadows moving across your eye, especially when you're looking up at the sky or at a white screen. Vitreous detachment, which is what I just mentioned, is when you have that shrinking vitreous which is pulling away from the retina, and it creates the risk of a retinal tear, which can cause retinal detachment because it's pulling sort of that layer of the eye with it as it shrinks. So, finishing off with our SVAs, which of the following is the correct order? So A, photoreceptor ganglion cell bipolar cell optic nerve. B, photoreceptor bipolar cell ganglion cell optic nerve. C, photoreceptor optic nerve bipolar cell ganglion cell. D, optic nerve photoreceptor bipolar cell ganglion cell. Or E, bipolar cell photoreceptor ganglion cell optic nerve. And the answer is B. Which condition is corrected by using concave lenses? A, hypermetropia, B, myopia, C, presbyopia, D, vitreous degeneration, or E, cataract. The answer is B, myopia. In the direct light reflex, which nucleus is responsible for sending information to the ipsilateral and contralateral nucleus that is linked to oculomotor nerve, or cranial nerve 3? A, the Edinger vasc valve, B, ciliary, C, pontine, D, pretectal, or E, vestibular. And the answer is D, the pretectal nucleus. So thank you so much for listening to the Neuro Crash Course, and again I'm sorry for the delay in uploading this. I wanted to re-record and have it perfect for you guys. So on the screen there you can see my email. Please feel free to email me at any point if you do have any questions about any of the topics, and I've uploaded our link tree where you can find any of our future courses on there. You can usually find at least one per month for each module that you'd expect to cover in medical school. If you scan that QR code, it will take you to a feedback form which will have my slides at the end. I would really appreciate if you could fill that in. But thank you so much for listening, and best of luck with any upcoming exams and good luck with medical school.